Welcome to the deep dive. Today we are putting on our surgical scrubs and really cracking open one of the most clinically crucial chapters in anatomy.
We are. We're looking at Gray's Anatomy, Chapter 60, all about the anterior abdominal wall.
And this is so much more than just a surface dive, isn't it?
Oh, absolutely. The abdominal wall is this flexible, multi-layered shield. It maintains our core integrity, but when it fails, which, happens constantly, it results in a hernia.
I've heard that hernia repair is just incredibly common.
It is the single most frequent operation that general surgeons perform. So our mission right now is to visually map this whole complex area, the layers, the vessels, the nerves, all the weak points, using just our words.
So you can actually picture the structures that really matter in clinical practice.
Exactly.
Okay, so let's start with the boundaries. Give us a mental frame of reference.
Right, so picture this area as a kind of curved hexagon. It extends from your thorax all the way down to the pelvis.
Okay, so what defines the top and bottom?
Superiorly, you've got the costal arches, your lower ribs, and the xiphoid process. Laterally, we go out to the mid-axillary line. And then inferiorly, you can feel the landmarks, the curves of your iliac crests, the inguinal ligament, and the pubic symphysis in the middle.
So that's our territory.
That's our territory. And now we start peeling back the layers like an onion, starting with the superficial stuff.
Right under the skin.
Yep, the subcutaneous fascia. Now, historically, it's described as two layers, campers and scarpas, but functionally, for a surgeon, it's really three.
So layer one is the superficial fatty layer, Camper's fascia, but the one right under that, what's its significance?
That's the membranous layer, Scarpa's fascia. And what's really remarkable about Scarpa's is its continuity.
Just keeps going.
It does. Unlike the fatty layer, this tissue stays well-defined, especially as you go lower. In males, it continues right into the perineum, becomes part of the dartos muscle in the scrotum. In females, it extends into the labia majora.
And that continuity must have clinical implications.
Huge. If you have, say, fluid leakage or a deep infection in the abdominal wall, that continuous Scarpa's fascia acts like a barrier. It directs the fluid along a very specific path, often right down into the perineum.
It dictates the spread of pathology. That makes perfect sense.
Okay.
Okay, and you mentioned a third layer.
Yes, the deep fatty layer. This one sits right on top of the deep fascia and the muscles. It's distinct, and it's the primary target for liposuction.
Ah, okay. Why that layer specifically?
Well, surgeons target it to avoid damaging these little tethering fibers in the more superficial layers. If you mess with those, you risk surface irregularities, dimpling.
I see. That's a key distinction for any surgical plan. So
Yeah.
let's punch deeper past the muscles to the deepest connective tissues.
Now we're at the transversalis fascia. It's a thin, almost see-through sheet that lines the deep surface of the transversus abdominis muscle.
But it's not just a uniform sheet, is it?
Not at all. It has these important thickenings. Inferiorly, it thickens to form the iliopubic tract, which runs parallel to but deeper than the inguinal ligament.
And that's a critical landmark in surgery, I'd imagine.
It's essential, especially in laparoscopic hernia repair. It's a key anchor point for mesh, and it gets confused with the actual inguinal ligament all the time.
Okay, so what about openings in this fascia? Is there anything reinforcing the deep ring itself?
There is. Right at the medial edge of the deep inguinal ring, the fascia is reinforced by something called the interfoveolar ligament. It's a subtle but important structural brace.
And then lining all of this.
Right. Between the transversalis fascia and the peritoneum, you've got the extraperitoneal connective tissue.
Which sounds kind of unimportant, but it often has fat in it. And isn't that fatty tissue usually the first thing to pop through a small hernia?
It is. It's often the first thing that protrudes in a small epigastric or umbilical hernia. But that fat also has a really critical surgical function in big repairs.
How so?
If there's enough of it, you can actually separate the peritoneum from the deep fascia and use that tissue to create a peritoneal flap. It's vital for covering large mesh placements.
Moving from structure to logistics, let's talk supply lines. The wall is incredibly vascular.
Incredibly. Primarily from these vertical systems running right behind the rectus abdominis muscle. You have the superior epigastric artery coming down from above.
And the inferior epigastric artery coming up from below.
Exactly. The superior is the end of the internal thoracic artery. The inferior branches off the external iliac artery down in the pelvis. And where they meet is where the magic happens.
Now, you often hear the inferior epigastric called the dominant supply. Is there a real physical reason for that?
Oh, a very physical, quantifiable reason. The inferior epigastric artery has an average diameter of about 3 millimeters at its origin, the superior epigastric. only about 1.6 millimeters.
Wow, so it's nearly double the size.
It just carries a much larger volume of blood. That makes it the dominant source for the whole central abdominal wall.
And the connection between them, this anastomosis, is that important for collateral circulation.
It's crucial. Let's say your aortic flow is compromised for some reason. This connection provides a vital bypass around the blockage. And conversely, if pressure builds up in the portal venous system.
Like in severe liver disease.
Right. The small veins near the umbilicus, which drain into the system, they get massively dilated to relieve that pressure. That creates that classic radiating pattern of veins you see on the abdomen.
Caput medusae.
Caput medusae. It's the body trying to bypass a pressure lock.
So surgically, is the vascular map just those two vertical systems?
Well, surgeons actually break it down into 3 zones. Zone 1 is that central area dominated by the epigastrics we just discussed.
Okay.
Zone 2 is the lower hypogastric region, and Zone 3 is the lateral part, which gets its supply horizontally from the intercostal and lumbar arteries. Mapping these zones is critical for any flap surgery.
Speaking of vasculature, we have to talk about the anatomical landmine, the aberrant obturator artery.
Yes. The corona mortis.
The crown of death. That's a pretty stark name. Why is it so dangerous?
Because sometimes this pubic branch from the inferior epigastric is huge, and it runs right next to the femoral ring. If you're doing a femoral hernia repair and you're not anticipating it, any blind dissection or staple can lead to just catastrophic hemorrhage.
So you have to actively look for it?
You have to dissect deliberately, identify it, and protect it.
Let's switch to innervation. Where are the nerves coming from?
They're segmental. They're the ventral rami of T6 through T11, the subcostal nerve at T12, and then the iliohypergastric and ilioinguinal nerves from L1.
And they all travel in a specific path.
A very specific, very reliable path. They run forward in what we call the neurovascular plane.
And where is that plane?
It's situated right between the transversus abdominis muscle and the internal abdominal oblique muscle. It's a consistent landmark.
For anyone trying to put a pin on their mental map, the classic landmark is the umbilicus, right?
The umbilicus is the bullseye. The skin there is supplied by the 10th intercostal nerve, T10. So you know T9 is above, T11 is below. It lets you map all the dermatomes.
And knowing about that neurovascular plane has a direct clinical use.
A huge one. It's the basis for the transversus abdominis plane blockade, or TAP block. We inject anesthetic right into that plane, between the internal oblique and transversus abdominis.
And that numbs what exactly?
It blocks sensation to the skin, the muscles, and the parietal peritoneum of the wall. It gives amazing post-op pain relief without the risks of a central block, like an epidural.
So smart. Okay, let's move to the engine room, the 4 muscle pairs.
Rectus abdominis, external and internal obliques, and transversus abdominis.
They don't just move us. Their real job is generating that intra-abdominal pressure.
Yes, that synergistic contraction is the force behind everything from coughing to delivering a baby. The central feature here is the rectus abdominis.
The 6-pack muscle.
That's the one. Its lateral border creates that visible groove, the semilunar line, and running across it, you have these fibrous bands.
The tendinous intersections.
Exactly, usually 3 of them. They keep the muscle tethered to the front of its sheath.
Okay, now for the big visualization challenge. The rectus sheath itself. It's formed by the aponeuroses of the other 3 flat muscles, but its structure, it changes dramatically.
It has a complete architectural shift, and it all happens at one specific landmark, the arcuate line.
The arcuate line. So explain that visual shift for us. Let's start above it.
Okay, so above the arcuate line, which is about 1/3 of the way from the umbilicus to the pubis, the internal oblique aponeurosis actually splits. It sends one layer in front of the rectus and one layer behind it.
So the muscle is totally encased. It's got strong support both front and back.
Right, but then you go below that line and everything changes.
How so?
Below the arcuate line, all 3 aponeuroses, external oblique, internal oblique, and transversus abdominis, they abandon their posterior post. They all swing around to pass entirely anterior to the rectus abdominis.
Wait, all 3 of them move to the front?
All 3, which means the back of the rectus muscle is suddenly supported only by the really thin, deep layers.
Just the transversalis, fascia, and peritoneum.
Exactly. So that arcuate line, the end of the posterior sheath, becomes this major point of weakness in the lower abdomen.
Wow, that lack of support makes the midline structure, the linea alba, even more important.
That's the central seam, the tendinous raphe running from the xiphoid to the pubis, formed by all those interwoven fibers.
And when that widens, you get diastasis recti.
the separation of the rectus muscles, very common after pregnancy or with obesity. And it's crucial to remember this is not a true hernia. The fascial layers are still intact. They're just stretched and thin.
But it's a sign of weakness.
It's a big sign of underlying pressure that can lead to true hernias nearby.
Which brings us to the Achilles heel of the abdominal wall, the inferomedial region. Surgically, you call it the myopectoneal orifice.
Yes, and this is where you find the inguinal canal. It's this 3 to 6 centimeter oblique tunnel running downward and medially.
And it has two openings.
2 rings. It starts laterally at the deep inguinal ring, which is just an opening in the transversalis fascia, and it ends medially at the superficial inguinal ring, a triangular hole in the external oblique aponeurosis.
I always found the protective mechanism here fascinating, the shutter effect.
Yeah.
What's actually happening when we cough.
So when you cough, the internal oblique and transversus abdominis muscles contract hard. This pulls the roof of the canal down towards the floor, basically flattening the canal against the tough inguinal ligament.
It closes the shutter.
It tries to, yeah. It resists that spike in pressure, but it's not foolproof.
So to tell the different types of hernias apart, surgeons use Hasselbalch's triangle. What are the borders of that landmark?
Okay, so Hasselbalch's triangle is on the posterior wall of the canal. The inferior border is the inguinal ligament. The medial border is the edge of the rectus abdominis muscle. And the most important one,
The lateral border.
the lateral border is the inferior epigastric vessels.
That's the key. So if a hernia pops out lateral to those vessels,
It's an indirect inguinal hernia. It's following the path of the inguinal canal itself, often because of a congenital defect.
a persistent processus vaginalis.
Exactly. But if the hernia arises medial to those vessels, punching straight through the weakened floor of Hasselbalch's triangle,
That's a direct inguinal hernia.
and that's an acquired weakness from age or strain.
Okay, we have to separate those from the femoral hernia. Where does that one pop out?
A femoral hernia protrudes through the femoral ring, which is the medial part of the femoral sheath. It's located distal and lateral to the pubic tubercle.
And why are they considered so dangerous?
Because that femoral ring is really narrow and rigid, it makes them far more likely to get stuck incarcerated and have their blood supply cut off.
Strangulation.
Strangulation, a true surgical emergency.
What about those trickier hernias, like a Spigelian hernia?
The Sibelian is tricky because it's an interstitial hernia. It happens where the semilunar line crosses the arcuate line. The hernia passes through the deep muscle layers, but the superficial layer, the external oblique aponeurosis, often stays intact.
So you can't feel it easily.
Exactly. The deep defect is covered, so the lump is difficult or impossible to palpate. It leads to a lot of delayed diagnoses.
This detailed understanding of the layers is really why complex hernia repair has evolved so much, right? You're not just patching a hole anymore.
Not with massive ventral hernias, no. The goal is to bring the midline back together, which requires what we call component separation techniques.
And the classic method was the anterior component separation.
The Ramirez technique, yeah. The idea is you release the external oblique muscle on both sides. This gives you a massive amount of slack to pull the fascial edges to the middle, sometimes up to 20 centimeters.
But that anterior approach had a major downside, didn't it? Related to the vascular supply we talked about.
It did. To mobilize those big skin flaps, you often have to sacrifice the periumbilical perforating vessels. And that puts the skin at a huge risk of ischemia, of dying. It's a devastating complication.
Which led to the more modern approach.
The posterior component separation, or transversus abdominis release. The Rives-Stoppel-Wantz approach.
So what's different here?
This is now highly favored. You incise the posterior layer of the rectus sheath and release the transversus abdominis muscle. This gets you into the retromuscular space, this huge, well-vascularized plane behind the muscle where you can place a large piece of mesh.
And the blood supply.
Crucially, this technique generally preserves the main blood supply. You save the lateral neurovascular bundles and the central perforators. It's just a perfect example of how deep anatomical knowledge leads to better, safer surgery.
That shift from anterior to posterior really does illustrate why knowing every single layer and plane is so foundational. We've mapped Scarpa's fascia, the dominance of the inferior epigastric artery, the T10 dermatome, and that huge architectural shift at the arcuate line.
And if you connect it all to the bigger picture, you see this biological enigma. The inguinal canal with its sophisticated muscular shutter effect.
Right.
It's this clever protective mechanism.
It should work.
It should. But despite this dynamic structural defense, that region remains the single most common failure point for abdominal integrity in humans. It forces millions of repairs every year. It really just highlights an inherent weakness that evolution hasn't quite managed to solve.
A phenomenal deep dive into the anterior abdominal wall. Thank you for exploring this incredibly complex anatomical chapter with us. We hope you feel thoroughly informed.